Welcome back. For this lecture, we're going to continue talking about cardiac emergencies, and specifically for this lecture, we're going to talk about the EMT-Basic management of common cardiac emergencies. Emergency medical care for chest pain or discomfort, we've got a couple of fundamental care pieces that we need to be aware of as the EMT-Basic provider. So one, we need to make sure we ensure that the patient is in a position of comfort. And as mentioned several times before, if the patient is hypoxic, then oxygen is indicated and we should not withhold oxygen from that patient. Our target SpO2 is 94 to 99%. And should a patient be experiencing chest pain with hypoxia or even suspected hypoxia, then we certainly need to be giving oxygen. Depending on the protocol on where you work, you may be prepared to administer things like low-dose aspirin, or assist with nitroglycerin. Aspirin is a medication that we give to prevent blood clots from forming or getting bigger. It is not an anticoagulant, so to speak, or a clot busting drug. Rather, it prevents clots from aggregating together, platelets from aggregating together to make the clot any bigger. So it helps the clot from getting larger or getting more difficult to be removed. We give it in 81 milligram chewable tablets, and the recommended dose is 2 tablets to 4 tablets. More often than not, you're going to give 4 chewable tablets for a dose of 324 milligrams total. Nitroglycerin is available in several forms to give. Most commonly, we see the sublingual pill or sublingual spray. We administer that under the tongue, that's the term sublingual, but it also can be in a skin patch that's applied to the chest or a paste that's given across the chest. The mechanism of action for nitroglycerin is that it relaxes the blood vessel walls and helps increase the blood flow and oxygen supply to the heart. This decreases the workload of the heart, and by dilating those blood vessels allows for more oxygenated blood to get to the potentially compromised tissue. There are some significant side effects you need to be aware of with nitroglycerin. Firstly, it can decrease the blood pressure, and one of the contraindications we'll talk about is that if a patient has a blood pressure that's too low, we shouldn't be giving it. It can also cause a severe headache in your patients. So as mentioned, the contraindications, or things that would prevent us from giving nitroglycerin. One is a systolic blood pressure less than 100 millimeters of mercury. That's the top number in the blood pressure. So if their systolic is less than 100, we're not going to give nitroglycerin. Recent head injury, use of erectile dysfunction drugs within 24 hours. And the EMT should be inquiring about this as part of the history. And remember that erectile dysfunction drugs are not just taken by male patients. Female patients may take them, and they may not be taken only for erectile dysfunction. They may be taken for other vascular cardiovascular disease implications, or they may be taken as recreational use. So you should inquire about this through history and social history prior to giving nitroglycerin. Cardiac monitoring, so for chest pain patients particularly, an ECG can be reliable and useful, but the electrodes must be placed in consistent positions. This is something that we'll go over in lab and you'll have some opportunity to practice with, but we'll talk about those basic principles now. You may need to shave body hair. So these adhesive electrodes don't stick well to the body if there's a ton of hair. Most ambulances are equipped with a razor so you can shave that area. You may need to rub the electrode site with an alcohol swab prior to application to clean the oil and dirt debris off the skin. Attach the electrodes to the ECG cables prior to the attachment. So there's a clip that attaches the ECG electrode to the ECG cable, and you should attach those before placing the electrode, as trying to attach them on the skin is sometimes difficult. As far as general placement goes, you can see here a diagram for a 4-lead ECG on the left. You'll have 4 colored cables: white, black, green, and red. They also may be labeled LA, RA, LL, and RL respectively. So the LA, or the black cable, is the patient's left arm. The RA, or the white cable, is the patient's right arm. And left leg and right leg are labeled respectively. You can see that they're placed on the soft tissue of the trunk of the body. This is to prevent any artifact from bones and to try and prevent some movement or jostling of the electrodes to get an accurate ECG tracing. The 12-lead placement that you see on the right-hand side of your screen is additional electrodes V1 through V6 and are placed to get a more accurate view specifically of the ventricles of the heart. V1 is placed at the fourth intercostal space on the right sternal border, while V2 is placed at the fourth intercostal space on the left sternal border. The next electrode that we would place would be placing V4, which is the fifth intercostal space at the midclavicular line. We then would go back and place V3 directly in between V2 and V4. We would then place lead V6, which is V6 is the anterior axillary line on the left-hand side at the fifth intercostal space, and then we would go place V5, which is lateral to V4 in the anterior axillary line. So V6 goes in the mid-axillary, V5 goes in the anterior axillary. Once the electrodes are in place, we can turn on the monitor and print a sample rhythm strip. If the strip shows artifact, which is a noisy or chaotic baseline, this can often be an indication that the electrodes are not placed correctly or firmly enough on the skin. Many open heart operations have been performed in the last 40 years. It's not uncommon for us to see patients that are post-surgical that have secondary complications or perhaps another coronary event. Two of those common types of surgeries are coronary artery bypass graft. This is where a chest or leg blood vessel is sewn from the aorta to the coronary artery beyond the point of obstruction to bypass a clot. And then percutaneous transluminal coronary angioplasty is where a tiny balloon is inflated inside the narrow coronary artery and then a stent is placed. Patients who've had open heart procedures may or may not have long chest scars. It used to be common that you would see patients with a scar known as a zipper or a long scar down the center of their chest, but this is not always the case today as technology has advanced in surgical devices. And so even though the patient may have had a stent placed or surgical graft placed, you may not see significant scarring. Cardiac pacemakers are also common for pre-hospital providers to encounter. These are devices that are implanted within the chest that help maintain regular cardiac rhythm and rate. They deliver an electrical impulse through wires that are directly in contact with the myocardial tissue, and they're typically implanted under a heavy muscle or a fold in the skin in the upper left portion of the chest. It's not uncommon when you expose a patient for assessment, particularly a cardiac patient, to see a device in the upper left side of the chest, and that device that's implanted under the skin there is the cardiac pacemaker. The technology is very reliable, but it's not unheard of that they can malfunction, and a pacemaker malfunction or a runaway pacemaker is indeed an emergency, and you should be requesting ALS backup and preparing for rapid transport for these patients. Patients may also have automated implanted cardiac defibrillators, and this is used by some patients who have suffered a cardiac arrest in the past, and the defibrillator is in place so that it monitors the heart rate and can deliver a shock if needed. Treat chest pain patients with these devices just like any other chest pain patient having an acute myocardial infarction or an MI, and deliver aspirin and nitroglycerin as indicated, and consider ALS backup for these patients, certainly. An external defibrillator vest is a vest with built-in monitoring electrodes and defibrillation pads that's worn by the patient. It's attached to a monitor and can deliver high-energy shocks. Don't touch the patient if the device warns it's about to deliver a shock. Just like the external defibrillators that we use when we learn CPR, this device can transfer large amounts of electricity through the body, and if you're in contact with that patient, you're at the risk of being shocked. The vest should remain in place while CPR is being performed unless it interferes with the compressions. LVADs or left ventricular assist devices are also used to enhance pumping of the left ventricle. The most common ones have an internal pump and an external battery pack. One of the things that is unique about LVADs is that patients will most likely not have a palpable pulse. And when you go to feel for a pulse, you're not going to feel anything there. If the patient is awake and talking to you, the patient does indeed have circulating blood flow, and it's not that you need to start CPR. As a general rule, if the patient tells you to stop or that it hurts, you probably shouldn't be doing CPR. Make sure that you transport all supplies and battery packs with the patients. The patients typically have spare batteries with them or in their residence. As when the battery dies for these, their blood is no longer pumping. So it's important that you transport the patient with all of their necessary equipment. Cardiac arrest is a complete cessation of cardiac activity. You should be assessing for the patient's pulse at the carotid artery, a central pulse. Was terminal before CPR and external defibrillations were developed in the 1960s, but since the development of CPR and AEDs, cardiac arrest is occasionally reversible. It relies on high-quality CPR and early defibrillation. When we get patients back from cardiac arrest, it's very rarely due to advanced life support measures. It's due to early defibrillation and early high-quality CPR. So what you do when you arrive on scene for these cardiac arrest patients immediately will often be the determining factor on whether that patient ultimately survives or does not. The picture noted here is an AED, or automated external defibrillator. It analyzes electrical signals from the heart and identifies things like ventricular fibrillation, and then administers a shock to that patient in an attempt to correct the erratic cardiac activity. All AED models require some operator interaction, even if it's simply pressing the start button or the go button. Most of them are semi-automated, and they will analyze a heart rhythm and provide voice tones for you to follow. It will be common for it to tell you to stand clear of the patient while it's analyzing the rhythm. And then once it analyzes the rhythm, it will say something to the extent of shock advised or shock not advised. And if a shock is advised, it will say charging. Once it says charging, it will deliver another command prompt to deliver the shock. Once a shock is delivered, you need to immediately resume CPR. Fundamental are going to be the importance here. Fundamental interventions are the determining factor on whether a patient will survive cardiac arrest, and one of those is continuous high-quality CPR. Advantages of AED use is it quickly delivers a shock, they're easy to operate, and ALS providers don't have to be on scene. Some of them have a remote, some of them have larger pad areas to deliver more efficient shocks, and most of them will come with two types of pads, adult pads or pediatric pads, and it's important that you use the right pad for the right patients. Some things to consider is not all patients in cardiac arrest require shock. It is only designed to treat ventricular dysrhythmias that an electrical shock triggering would help reverse that dysrhythmia in that patient. All patients, though, in cardiac arrest should be analyzed by an AED. And asystole, or no heart activity, indicates, or asystole rather, is an indication of no electrical activity and is not a shockable rhythm. PEA usually refers to a state of cardiac arrest that exists despite an organized electrical complex. This would be an event where you feel for a pulse and the patient has no pulse and they're unresponsive and not breathing. But if you note on a cardiac monitor, or the patient is on a cardiac monitor, you may see electrical impulses that are present. Few cardiac arrest patients outside the hospital survive outside of the hospital arrest without early defibrillation. The American Heart Association has done a great job at publishing the chain of survival, which correlates to significant better outcomes for patients experiencing out-of-hospital cardiac arrest. And it relies on early recognition and activation of EMS, as well as immediate bystander CPR, rapid defibrillation, basic and advanced EMS access, and ALS and post-arrest care. And you can see here's an image of the 6 links in the chain of survival. CPR prolongs the period during which defibrillation can be effective. In patients experiencing ventricular arrests, CPR is what's going to keep them alive long enough to get the AED applied, the shock delivered, and the dysrhythmia corrected. Oftentimes, patients get resuscitated in cardiac arrest from ventricular fibrillation, and non-traditional first responders are being trained in AED use, including civilians, high school students, law enforcement. Any number of folks are trained in how to use an AED because of its success in converting out-of-hospital cardiac arrest. ALS and post-arrest care focuses on supportive care for circulation and oxygenation and ventilation. So if an ALS unit arrives on scene, they're going to continue ventilation and maintain oxygen saturation, assure adequate blood pressure in a post-arrest environment. There may be some targeted temperature management, although this tends to ebb and flow in favoritism with medicine on its effectiveness in post-cardiac arrest care. And recovery can take a year or longer for patients who survive out of hospital cardiac arrest. Work with your AED and CPR in sequence, and you'll have an opportunity to practice this in lab, but we want to minimize the interruptions in CPR, even for use with the AED. So understanding how the AED works and its prompt cycle works will help you minimize that that CPR interruption time for the patient. Make sure that you don't touch the patient during the analysis phase or the defibrillation phase, but you can certainly perform CPR once the analysis is complete prior to the delivery of the shock. And once a shock is delivered, you should immediately resume CPR. AEDs do have to be maintained, and each manufacturer provides a list of recommendations for its regular maintenance schedules. In the event that you have an AED failure, make sure that's documented and make sure that you report that to your either field supervisor or logistics person to ensure that AED can be serviced. Medical direction should approve written protocols for AED use, and continuing education with skill competency is generally required for EMS providers. As part of your post-credential recertification training or your continuing education, you should be continuously practicing with the AED and ensuring you're familiar with its use. In preparation for cardiac arrest, make sure that the electricity doesn't injure anyone. Make sure you're not touching the patient while the defibrillator is operating. Don't operate the defibrillator in pooling water, and don't operate the defibrillator if the patient is touching metal. Carefully remove any nitroglycerin patches that may be on the patient's chest and wipe with a dry towel prior to shocking. If the patient's chest has a significant amount of hair, make sure you shave the chest area where the pads are going to go to increase the conductivity of the electricity. Grab a history from bystanders or anyone on scene, or take scene clues to make sure that you can help determine the nature of illness or mechanism of injury, and call ALS assistance in a tiered system. If ALS is available to you, make sure that you're reaching out to them. Begin chest compressions and attach the AED as soon as available with witnessed cardiac arrest, and follow your local protocols for patient care after AED use. After the AED protocol is complete, one of the following is likely. Either the pulse is regained, no pulse is regained, or no shock advised, and no pulse is regained and the shock is advised, in which case you would deliver subsequent shocks and repeat the process. Wait for ALS to arrive while you're performing CPR when indicated, and continue shocks and CPR while on scene. If ALS is not responding and protocols agree, then you should begin your transport when the patient either A, regains a pulse, or 6 to 9 shocks have been delivered. The AED gives 3 consecutive messages every 2 minutes of CPR advising no shock. The best care for the patient in an out-of-hospital cardiac arrest is going to be where the patient lies. And so immediately taking a patient and moving them to the ambulance or transporting them, aside for scene safety reasons, is going to be counterproductive for the patient's outcome. And the best chance that patient has for survival is immediate CPR while on scene, placement and use of the AED. If you have cardiac arrest during transport, you should stop the vehicle. Research has shown that CPR while moving down the road is not very effective, and indeed inhibits an appropriate recovery for that patient and likely inhibits their ability to recover from out-of-hospital cardiac arrest. So you should stop the vehicle and begin the CPR. If the AED is immediately available, you should call for ALS support and follow the prompts on the AED. When coordinating with ALS personnel, if an AED is available, don't wait for ALS to arrive. Go ahead and place the AED. Notify ALS that you have a cardiac arrest on scene, and don't delay with defibrillation. Once the paramedic or the ALS provider arrives, they may swap out the pads for their cardiac monitor. That just allows for a little more flexibility in delivery of electricity. But you should keep doing CPR, and again, minimizing interruptions to CPR is the most important component here. At the raw score, return of spontaneous circulation, you should monitor for respirations. If indicated, provide oxygen via bag valve mask, again at a rate of 10 to 12 breaths per minute. Maintain an SpO2 between 95 and 99%, and see if the patient can follow simple commands if they begin to regain consciousness. Assess their blood pressure and immediately begin transport if ALS is not en route or per your local protocol.